This is Hubwonk. I'm Joe Silvaggi. Welcome to Hubwonk, a podcast of Pioneer Institute, a think tank in Boston. In 1992, a well-intentioned targeted program named 340B required pharmaceutical companies to provide eligible hospitals with drugs at a substantial discount for the benefit of uninsured patients. Those hospitals were then to use any savings and profits from the program to provide comprehensive services for the poor and uninsured. Since its inception, however, healthcare systems have exploited the statute's vague guidance to reap billions in profits by purchasing 340B drugs at a discount and then selling those deeply discounted drugs to insured patients at retail prices. Perhaps more disturbing is the trend that while 340B program profits have soared, access to discounted drugs and charity programs for the uninsured have been in steady decline. The numbers involved in this distorted drug program are staggering, now exceeding the value of both the Medicaid drug benefit and Medicare Part D. How did this worthy program get so distorted? And how can policymakers reform 340B in a way that realigns incentives to better serve the uninsured? My guest today is Pioneer Institute's visiting fellow in life sciences, Dr. Bill Smith, who will talk about the findings in his recently released paper entitled 340B Discounts, an Increasingly Dysfunctional Program. In the paper, Dr. Smith describes the arc of how this well-intentioned program seems to have lost its direction and grown to generate massive profits for hospitals, while simultaneously reducing drug benefits and charity programs for the uninsured. Bill will offer his views on what legislatures can do to realign program incentives to better guarantee the uninsured receive their drug benefits and ensure that profits from the program go toward our poorest citizens. When I return, I'll be joined by Pioneer Institute's Dr. Bill Smith. Okay, we're back. This is Hubwonk. I'm Joe Silvaggi, and I'm pleased to be joined by Pioneer Institute's visiting fellow in life sciences, Dr. Bill Smith. Welcome back to Hubwonk, Bill.
Thank you, Joe. Glad to be here.
Great. Well, Bill, I found your recently released Pioneer report entitled 340B Discounts, an Increasingly Dysfunctional Program. I found it somewhat alarming. I want to set the stage for our listeners that we're talking about a federal program designed to help low-income uninsured people afford medication. And it's largely been exploited by the medical community to reap literally billions in profits, with little of those billions going to where the statute was intended. So there's a lot to unpack in your paper. So let's start with some history. Let's start at the beginning. What was the original idea behind 340B, and when did the program begin?
Well, it actually didn't begin as a federal program. It just began when a number of drug companies, many drug companies actually, started giving deep discounts to hospitals that treated a large number of uninsured or low-income patients. The drug companies knew that those hospitals were struggling financially, and so they made voluntary concessionary discounts available to them. And in 1992, the federal government decided, the Congress decided, well, we're going to make this program mandatory. So we're going to require that the drug companies give discounts to hospitals that treat large numbers of low-income or uninsured patients. And you know, the program started out fine. I would have supported it in 1992. It targeted about 500 hospitals and clinics around the country. It was limited, and it was largely limited to those hospitals and clinics that did treat large numbers of low-income uninsured. But starting in about 10, 15 years ago, the program absolutely exploded. You become eligible as a hospital to become eligible for these 340B discounts based on the number of patients Medicaid patients you treat. The federal government and the Congress thought that's a proxy for you're treating low-income or uninsured patients. And when they expanded the Affordable Care Act and Medicaid exploded in the number of patients, many, many more hospitals became eligible. So the program started out with about 500 hospitals. It now has about 2,500 hospitals. And those hospitals have expanded to satellite offices. So there are now 37,000 covered entities in the program.
So your paper does suggest that much of the reason it's exploded and the eligibility has expanded is owed to the vagary of the statute. You know, as you mentioned in your paper, it was originally designed to target quote unquote covered entities, but left it to the system itself to infer who was covered. Say more about how these vagaries are easily exploited.
Well, let me first explain why the program is so popular with hospitals and why it exploded. So under the 340B program, you can get a substantial discount when you purchase a drug. So let's say a hospital, just to make it simple, a hospital can purchase an oncology drug for $25,000 when the list price of that oncology drug is $100,000. So they're getting a 75% discount. So if you as a hospital administrator can lure into your hospital or to your satellite office a patient that has insurance and is wealthy, you can dispense that drug to that patient for $25,000 and then bill his insurance company or Medicare for $100,000. And you can pocket the $75,000 spread. This is basic arbitrage. It happens in many areas of business, but this 340B program is now being arbitraged. And the statute, getting back to your original question, the statute was written in poorly. So the program is not limited to only dispensing drugs to low-income patients or in low-income neighborhoods or to uninsured patients. So the statute didn't define anything about who's eligible for the program and who might share in these drug discounts.
I see. So now you said it's grown substantially since its inception. In your first answer, you did say the original program used Medicaid patients as a proxy for implying that a hospital is located where there are lots of Medicaid recipients, and inferred from that that there also must be lots of charity cases. Describe for our listeners, where were these original 340B participant hospitals, and where have they, sprung up now? Who's joining the system from where it used to be?
Yeah, so originally, Joe, that's a good question. Originally, these hospitals and clinics were in low-income areas, both rural and urban areas that treated large numbers of low-income patients. But since 2004, there's substantial data to suggest that a lot of these hospitals and their satellite offices are being located in wealthier areas that have higher rates of insurance. And that's in part due to the fact that they can arbitrage the drug discounts. So they want to get patients in there that have Medicare or commercial insurance coverage, because then they can bill for the full price of the drug while they buy the drug at the discount.
Now, your paper, we're talking about a program that was originally intended to help people who didn't have insurance. Now, in the meantime, we've passed the Affordable Care Act. Its stated intent and its effect, I think, has been to have more people become insured, both low income or people who had formerly been on Medicaid or uninsured altogether. So if we have fewer people who would be, in theory, eligible for 340B benefits, did we see a decrease in the amount of 340B activity once the Affordable Care Act was implemented?
Joe, just the opposite. In 2012, there were 54 million people covered under Medicaid. And this year, there are 83 million people covered under Medicaid. So the number of people insured has grown substantially. The number of uninsured has dropped dramatically. One would have expected, given that the 340B program was supposed to treat the uninsured, one would have expected that the 340B program would have declined over the past decade. Just the opposite. That's when it had its most explosive growth over the last decade. So it's up to about $38 billion in sales. And the 340B program will soon eclipse in size both the Medicaid drug program, which has 83 million recipients, and the Medicare Part D program, which has over 50 million recipients, and they're senior citizens who tend to use a lot of drugs. So we may be wonkish talking about a 340B program that nobody really knows about, but it's now the largest federal drug program in the United States.
Yeah, the numbers are staggering when you compare it to what we already consider fairly costly programs, Medicaid and Medicare Part D. To eclipse those programs is saying something. So I think that's why this program deserves our attention. Now, let's set aside that despite the fact that the ACA has more people insured, and therefore one would think the byproduct of that would be fewer 340B claims, they went up. So that means hospitals were generating more money from this program than they had before the ACA. Another feature of that 340B I don't think we've addressed is that the program was supposed to help hospitals use the savings they get from those discounts and apply those to programs for charity. In other words, they're supposed to take the benefit and apply that benefit to charitable patients. Have we seen an increase in the amount of money that hospitals are giving to charity owing to their, this windfall of a program?
Yeah, Joe, just the opposite. We've seen charity care decline, and it would have been very difficult for me to write a paper critical of the 340B program had the billions of dollars that this program is generating been devoted to programs for low income and uninsured. But that's just not the case. I don't want to pick on Mass General because they're an excellent hospital. They're part of the whole life sciences ecosystem here in the greater Boston area. But in 2013, they were spending 3.8% of their revenues on charity care for low-income people. And in 2020, that dropped to 1%. It's been a straight line down, as it has in many hospitals. And at the same time, we know that they're expanding their 340B presence. They had one pharmacy dispensing their 340B drugs in 2017. They now have 132 pharmacies dispensing their 340B drugs. So we know the revenues are growing. They're not required to disclose the amount of revenue they're getting from 340B, but it must be explosive if you've gone from one pharmacy to 132 pharmacies. And Mass General has expanded. They have offices now in some of the wealthiest towns in Massachusetts: Wellesley, Concord, Waltham, Newton. They even have offices in Nashua, New Hampshire, and York, Maine. And part of the reason for this growth is that they can leverage these 340B discounts in these areas. So it's a troubling thing, particularly because the charity care numbers have been declining.
I found a striking feature of your paper in that that originally the 340B was going to hospitals that did more charity work. Your paper points to the research that indicates that what these newer hospitals, these bigger hospitals, I don't want to throw the Mass General under the bus, but when compared with those hospitals that don't participate in 340B, in theory, those that don't do substantial charity work, there's actually less charity work being done in 340B hospitals than there are in non-340B hospitals, which is to say there's no correlation between one's inclination to exploit 340B and one's inclination to serve charity cases. This is very troubling. Say more about this phenomena.
Yeah, that's precisely right. There are studies to suggest that 340B hospitals give less charity care than either government or for-profit hospitals. And one would expect, given the revenues that are generated from the 340B program, which are estimated to be $40 billion for these hospitals, that the nonprofit 340B hospitals would be dispensing much more charity care, but the data suggests that's not true.
Well, you break down three types of hospitals, I suppose. I've never thought of it this way, but there's for-profit, nonprofit, and government. So for-profit is supposed to be the bad guys, I suppose, in a modern narrative. Nonprofits, the good guys. Your paper suggests that nonprofits are, in measurable terms, doing the least amount of charity work when compared with for-profit and government hospitals. Say more about that data.
Yeah, and I don't want to, Joe, I don't want to cast I don't want to paint with too broad a brush here, because we did find hospitals in urban areas in the Boston area, such as Boston Medical Center and Cambridge Hospital, Everett Hospital, they were giving out a huge amount of charity care, more than 10% of revenue some years. Unlike Mass General and UMass Memorial in Worcester and Bay State in Springfield, where the numbers are closer to 1%. So there's some hospitals and clinics that are really doing the Lord's work when it comes to charity care. And so I don't want to paint with too broad a brush. But on average, charity care has been declining at these nonprofit 340B hospitals, which one would not have expected given the growth in the program.
Sure. And you mentioned briefly that the 340B programs are branching out to smaller more affluent communities, but local community physician groups themselves. How does the 340B program interfere with community physician practices?
Well, to be frank, the hospitals are just buying up community-based practices. 51% of the community-based oncology practices are now vertically integrated into a hospital system because they've been bought up. And the reason they've been bought up is obvious, because in neurology and oncology and in those specialty areas where you're dispensing expensive drugs, you can keep the spread as a hospital system and arbitrage the 340B discounts when you purchase an oncology practice and bring in a huge amount of revenue. So this is troubling because people like community-based practices. They don't want to see their local community physician practice being bought up by a hospital. But it's also the case that once these practices are bought up, there is an incentive not only to prescribe more drugs, but to prescribe more expensive drugs, because you're going to be able to leverage those discounts. So it's not great all the way around. And you know, the oncology community is well aware of this problem, and they've been fighting back, trying to avoid the purchase of some of these community-based clinics.
So if I'm someone who enjoys a community physician practice, some may say, "Oh, I'm indifferent to who owns or how vertically integrated my system is, my doctor is." But what your paper points out is once it does join this integrated system, everything in that practice becomes substantially more expensive. Not unlike were that practice to move into the city, the drugs, the physician visits all go up in price. And you also mentioned in your remark that given that the hospitals arbitrage the difference between what it's a percentage based, the more expensive the drug, the greater the discount, the greater the profit. There's a clear incentive to raise drug prices based on the difference between the retail and the 340B discount.
Yes, and again, it's not just drug prices that go up. Overall healthcare costs in the hospital setting are more expensive generally. And so, I'm very sympathetic to hospitals. My sister's a hospital administrator in New York, and I know it's a difficult business, but it is more expensive to treat somebody in a hospital setting or a hospital satellite office than in a community-based physician practice. That's just the reality. And so this expansion of hospitals into wealthy suburbs is going to drive up healthcare costs and is driving up healthcare costs.
So sort of the icing on the cake before we shift gears into what you recommend as perhaps a useful remedy for many of these perverse incentives, you describe a case whereby when combined with a Medicaid rebate, a drug company that sells a drug, I think you use it, for instance, a $100 drug that winds up costing the drug manufacturer money to sell the drug, which seems unbelievable. But many people like to trash the reputations or incentives of drug companies, but to have a system whereby a drug company loses money for every pill it sells. To say more of how 340B and the Medicaid rebate might combine to make a negative margin.
Yeah, so it's simple. It's a problem called duplicate discounts, which were banned in the original statute. It's actually a violation of federal law for a pharmacy to obtain duplicate discounts. So let's say you buy a drug at $25, which is the 340B price. And then the patient goes to the pharmacy and the drug is purchased. And then the pharmacy bills the drug manufacturer for a $35 rebate. The company now has just lost $10 on that sale because they're getting both the 340B discount as well as a Medicaid rebate. And this is a common problem. It's in the hundreds of millions of dollars probably that these duplicate discounts happen every year. And it was banned in federal law, and one would think with our current software systems, they'd be able to solve this problem, but they haven't. And inspectors general and all sorts of people, the Justice Department and others have come back and said, you got to solve this problem, but they have not.
Indeed. All right, so let's stop piling on. We established that 340B has created some perverse incentives, and those of us who pay into this health system are all poorer for it. let's figure out how to what you would recommend as reasonable steps towards finding some remedy or solution to this. First, you would recommend that we require hospitals to report 340B revenues. It seems odd that we don't already do that, but say more about why that's important.
Well, that's important because they do report, although the definition of charity care needs to be tightened up. They do report in their Medicare cost reports the amount of charity care that they dispense. So if we knew what they were securing in revenue from the 340B program, we could compare that with the amount of charity care that they're giving out each year. And one would expect that there's a great disparity between the two numbers these days. And, the transparency might shame them into spending more on charity care, which would be a good thing.
Indeed, indeed. Now, those presumably, it's a positive number, the difference between the money they get from 340B and the money they give in charity care. You would want to, your second recommendation is to require those covered entities to spend that money, that profit, on charity care. That seems reasonable. Is that what you're saying?
Yeah, it's a more directive than just the transparency option. But you could require that all revenue that's secured through the 340B program must be spent on community programs that serve low-income and uninsured patients. It'd be that simple. Right now, we don't know where all that revenue goes. It could go to hospital salaries. It could go to, who knows, could be go to expanding the building. We don't know where the money goes now. And requiring it to go to charity care would be a boon to charity care around the country.
Indeed, that's how it was intended, so it ought to go to the charity. You also want to better define who is eligible for the discounts and the charity care, which you addressed early in the paper, that remarkably, it doesn't specifically define who should be eligible.
Yeah, I'm not sure why a 340B drug should be given to a millionaire in Wellesley. I don't think that fits but that is happening. That is happening now. I don't think that fits the original spirit of the program, and the statute needs to be tightened up so that doesn't happen.
Indeed, and that dovetails well with the next point, which disqualified 340B child sites, the satellite sites, we're using that term, in wealthy communities. I'll just say, let me qualify this. I'm sure there's some low-income people in Wellesley, probably not many, but we keep going there. But let's say let's use that example again. Why would we disqualify the 340B sites in wealthy communities?
Well, charity care arises many times spontaneously. It's the homeless person who finds himself in the emergency room and doesn't have insurance, and the hospital has to eat the costs of that care. And so if you're locating your satellite offices in wealthy neighborhoods where people have high rates of insurance, you're not going to get that spontaneous charity care happening. So I think they ought to limit the places where these 340B sites can be to areas that are considered somewhat impoverished in the United States. And I don't want to come up with an exact definition of impoverished, but it should be in areas where you are going to get those walk-in patients who aren't insured and are very low income. And that originally, when they first enacted this program, that was happening. These hospitals and clinics were located in these areas, and there are some that are still located in these areas. But with the expansion, they've more and more expanded this program into wealthier areas that have higher rates of insurance.
And I think then the flip side of this is your next recommendation, which is not only define who is eligible, but when we say, let's take that money and give it dedicated to charitable programs, we should define what charitable programs look like and what community programs look like. We still haven't done that.
Yeah, the definition is not as tight as it should be. So for example, if a middle-class patient comes in and they owe a deductible or a co-insurance payment on whatever treatment that they were given in the hospital, and they never pay that, is that charity care? Well, some hospitals do define it as charity care because they're eating the cost, but the patient probably can afford the co-insurance payment and chooses not to pay it. So maybe it's not charity care. I just think they should tighten the definition so that these are programs that are serving underserved populations.
And you also, of course, want to reform how hospitals become eligible for this program. You want to reform the disproportionate share hospital eligibility requirements for the program. And in a sense, I think you're implying that some hospitals ought not to even be in the program.
Yeah, as we discussed, when the Affordable Care Act expanded Medicaid drastically, yeah, I think it's 11.75% is the percentage of Medicaid patients that you treat. You become eligible for it to become a 340B hospital once you cross that 11.75 threshold. And it's clearly the case that some hospitals have lured in Medicaid patients to get to that number, obtain 340B status, and then not gone further. Their Medicaid patient numbers are still at that level. So they're gaming the system to some degree. Not all hospitals, but some hospitals for sure. So I think they ought to look at Medicaid as a proxy for treating low-income patients. I'm not sure is a workable definition any longer, given the expansion of Medicaid. And they maybe ought to look at other numbers, like how much charity care they give out. That could be a threshold that makes you eligible for 340B status.
That would be something to earn that status based on how much good you do, rather than how many Medicaid people you lure in.
Precisely.
And the final one, I'm not sure I know precisely why this is a benefit, but you suggest we should convert 340B programs from discounts to rebates. I guess it must be conditioned, that rebate's conditioned on proof that it's being used for the right thing.
Yeah, it's complicated, but the rebate system would avoid the problem that we discussed with duplicate discounts, because you'd have a little time to figure out who was a Medicaid patient and who wasn't before you wrote the check, who was getting a 340B drug and who wasn't. And so the rebate system would help solve that problem. The pharmacy transactions are extremely complicated, but I'm told by people who know them well that a rebate system would solve the duplicate discount problem.
All right, so those are your recommendations. But our listeners may think, okay, this is fine, but you know what? We're here in Massachusetts. We're the good guys. Our hospitals are above reproach. But you name names in the end of the report, and not all Massachusetts hospitals come out wearing the white hat, I guess. So let's name names and talk about where you see problems, and where we'll call out some other hospitals for doing a terrific job. But before we name names, how do you measure? You talk about in your report who's really not using the money for charity work. How do you measure charity care provided in a given system and any given hospital?
Well, in our report, we looked at Medicare cost reports that hospitals have to file every year with CMS, the federal Medicare Medicaid agency. And they're required to report their charity care numbers based on their revenues. So what we did in the report is we picked 5 hospitals randomly. We picked by geography. We wanted to see how across the state charity care was being given out. So we picked Mass General in Boston. We picked UMass Memorial in Worcester. We picked Bay State in Western Mass. We picked Berkshire Hospital System in the Berkshires, and South Coast hospitals on the Cape. And what we found is those hospital systems were not picked in advance based on their charity care numbers. We hadn't even looked at the charity care numbers. But what turned out to be the case is for all those 5 hospital systems, the charity care numbers are a straight line down from 2013, 2014 till this year. So that's a problem. And again, we didn't want to dust up all hospitals. So we looked at the numbers and we found there were hospitals like Boston Medical Center and Cambridge Hospital and Everett Hospital that were giving out large amounts of charity care based on revenue. So again, I don't want to paint with too broad a brush, but in our random sample based on geography, all the charity care numbers were down.
So let's put that in the numerator. The denominator then is how much the program has grown in Massachusetts. You cite some numbers, I don't know if you have them at your fingertips, how in the last 8-10 years the money has grown. You've established that the money given to charity by those hospitals from the 340B has been going down, but the revenue coming in from 340B has grown. Can you put a fine point on how much it's grown in Massachusetts?
Well, we don't know because the hospitals aren't required to disclose their revenues, which is one of their from 340B. But we know nationally, the program has grown from about $9 billion in 2009 to $38 billion last year. So given that Massachusetts is hospital intensive, one would think they were reaping the benefits of that. And as I said, Mass General only had one pharmacy in 2017 that dispensed 340B drugs, and now it has 132. So I think we can say with a high degree of confidence that revenues from the 340B program have exploded. We just don't have an exact number because they're not required to disclose it.
So while the money going to charity has been going down across the board, by my reckoning, the money coming in from 340B across the country has back of the napkin quadrupled or seen a 400% increase over the last, what do we see, 8 years. That's
yes, and the 38 billion in actual sales, that's the discounted sale price. But one economist did a study arguing that 38 billion in sales leveraged an additional 40 billion in revenue for the hospitals. So this is a huge program. $78 billion in money is flowing through this program, according to some estimates.
Now, we can't go through all the findings of all the hospitals that you name, but let's start with you mentioned Mass General a few times. So let's get to it. How did a so-called man's greatest hospital fare in your study when comparing its revenue to its expenditure?
Yeah, in 2013, based on the Medicare cost reports, Mass General was devoting 3.8% of their revenue to charity care, which is a fair number. It's not real high, but it's a fair number. And in 2020, their charity care number dropped to 1% of revenues. So it's declined substantially. And we found that in the other 4 hospital systems around Massachusetts. And as I said, one would expect that their 340B revenues are exploding because they've gone from 1 pharmacy to 132 pharmacies that are dispensing 340B drugs. I just would like to see the numbers on their revenue from 340B and what it's been over the past decade or so.
This is all interesting because I think adding to perhaps our listeners' outrage is in the time between our 2014 and now, the Affordable Care Act has taken hold, which in theory would mean fewer people are uninsured. We know that to be true. So that this shift from higher 340B claims and lower charity is with the backdrop of saying there are few people who ought to be eligible. So the hospitals have to either claim that there are more charitable patients despite ACA, which seems impossible, or less need for charity despite the fact that their claims are going through the roof. Am I right?
Yes, and one study concluded there's an inverse relationship between charity care and growth in 340B programs, an inverse relationship. As 340B grows, charity care declines, was the conclusion of this one study, which I think is unsupportable. I just, again, it would be hard to criticize the size and scope of this program if all of this money were going to charity care, treating homeless people, uninsured people, providing mental health services, doing whatever for patients that are really in need. But that doesn't seem to be the case.
This is a real shame. More than a shame, as I say, but let's not call everybody out. We actually have some good actors in your group that you say you chose randomly. There were some good actors who are have high fidelity to their charitable mission. You call out Cambridge Health Alliance and Boston Medical Center. What do their numbers look like?
Yeah, again, their numbers weren't a straight decline from 2013 to the present. They went down some years and then back up some years, but they were substantially higher, even 10 times higher than some of these other hospital systems. So I think there are some hospitals that are doing right by this program. And I also have the impression that there are a lot of clinics, Ryan White clinics, federally qualified health centers, and smaller clinics that are located in very difficult, challenged neighborhoods that are providing great service. And they need these 340B discounts. And I don't want this program to go away. And I didn't write the paper to say the program shouldn't exist. It just needs to be tightened up. And the people that really need these discounts should continue to get them. And the people that don't shouldn't.
Indeed. So where now we're getting close to the end of our show. Where can our listeners find your paper?
Well, pioneerinstitute.org. The Pioneer Institute's website has both a press release explaining the paper as well as a link to the paper itself. And it's about 15 pages or so. It's not burdensome to read.
No, indeed. And I went deep into some of the footnotes. Copious number of footnotes also, which is good, supporting your observation. Now, our listeners, again, I'll use this as our last question. Our listeners are thinkers. They like think tanks, but they like to do. What would you suggest? I mean, you've laid out what let's say lawmakers can do. Would you recommend that our listeners, if they're persuaded, maybe they may be some of our congressmen are listening to the show, but those who are voters, what would they do if they want to encourage their legislator to jump on this out of compassion for the poor and the desire to see this substantial amount of money go to the right place? What should they do?
Yeah, I'm big on transparency. I think both on the state and federal level, there should be some disclosure on the part of hospitals about the amount of revenue they're securing from the 340B program. Requiring them to spend it on charity care, maybe not, but definitely disclosure and transparency. And, if I were just an ordinary citizen meeting with my legislator, I'd say, well, how come I don't know how much Mass General is getting from this program and how much they're spending on charity care? And let's look at the differential between those two numbers.
Indeed. Transparency or sunshine is the best disinfectant. At the very least, we might be able to shame these hospitals into giving the money they've been given as charity themselves. It was intended for charity. Make sure if they are getting it, we can then reasonably ask, well, what are you doing with that money? Do I have that right?
I agree 100%. Transparency, I'm not a big government guy. I don't want the government to be directive on everything. But just knowing the amount of revenue that are flowing into these hospitals from this 340B program, and then comparing it on the amount of community programs for low income and uninsured, that would be a valuable data point.
Wonderful. Well, let's end our show there. Thank you again for being on Humbug, Bill. You've been great.
Thank you, Joe.
This has been another episode of Hubwonk, a podcast of Pioneer Institute. If you enjoyed today's episode, there are several ways to support the show and Pioneer Institute. It would be easier for you and better for us if you subscribe to Hubwonk on your iTunes podcatcher. If you'd like to help make it easier for others to find Hubwonk, it's always welcome if you want to offer a 5-star rating or a favorable review. We're always grateful if you share Hubwonk with friends. If you have ideas or comments or suggestions about future episode topics, you're welcome to email me at hubwonk@pioneerinstitute.org. Please join me next week for a new episode of Hubwonk.